National demand for registered nurses is projected to surge 21% by the end of the decade. This need is currently colliding with a severe shortage of clinical placement sites and nursing faculty. This creates an educational bottleneck where seats are scarce and programs have zero margin for error. A student who drops out represents a lost opportunity to address the staffing crisis. Administrators typically respond by implementing strict cognitive gatekeeping, relying on high prerequisite GPAs and standardized assessments like the Test of Essential Academic Skills, or TEAS, to filter applicants. While these cognitive metrics demonstrate strong early predictive validity, longitudinal data and structural equation modeling suggest that exclusive reliance on them leaves significant gaps in actual workforce competency. Optimizing nursing admissions serves as a primary defense against systemic health cap collapse. The TEAS version 7 acts as the baseline cognitive predictor. Researchers isolate the reading and science domains as the most critical indicators of readiness. Reading scores serve as a proxy for a student's capacity to process complex medical protocols and integrate information from charts and graphs accurately. Science scores indicate the biological literacy required to master pathophysiology and pharmacology, the academic pillars of the nursing curriculum. This scatterplot illustrates the relationship between TEAS scores and early success. For registered nursing students, the correlation coefficient is 0.458. Among practical nursing students, it reaches 0.519. Supported by a p-value under 0.0001, this confirms a reliable connection between academic preparation and early outcomes. This predictive strength remained consistent even through the COVID-19 pandemic. Despite the shift to remote learning and increased student stress, the core cognitive skills measured by the TEAS continue to correlate with academic persistence. Ultimately, foundational cognitive intelligence remains a highly consistent predictor of a student's capacity to maintain clinical safety in the real world. However, a correlation coefficient only tells part of the story. To see where testing reaches its limit, we have to look at the variance explained, or R-squared. The TEAS only explains approximately 21% of the variance in early nursing school success. This leaves nearly 80% of a student's potential success tied to unmeasured, non-cognitive factors. Ignoring this gap leads to rigid cut scores, where programs set a hard minimum for entry. This causes a restriction of range. Raising scores may filter the pool, but it doesn't ensure applicants possess specific traits required for clinical practice. One study found that a minimum TEAS score of 63% led to a 75%. Furthermore, high testing thresholds can disproportionately eliminate diverse candidates who face secondary education inequities, despite their high clinical potential. While cognitive tests measure academic potential, using them as a solitary gatekeeper can reduce cohort diversity and overlook a student's capacity for clinical judgment. Quantifying the unmeasured 80%. Because it uses multiple independent raters, the MMI shows little to no bias based on age, gender, or nationality. This predictive power translates to clinical practice. A longitudinal study showed that a 7-station MMI model is a valid predictor of a student's performance in Year 3 outcomes. Human compassion and ethical fortitude can be assessed through these standardized, repeatable protocols. Admitting the right student is only the start. Success depends on the transition to practitioner. Researchers use structural equation modeling to track how post-admission variables influence workforce competency. In this model, formal nursing training and technology integration act as the primary inputs. These inputs contribute directly to the ultimate development of workforce competencies. However, the relationship is mediated by two psychological factors: self-efficacy and social support. High self-efficacy, the student's belief in their own capability, is a significant predictor of job satisfaction and clinical retention. Social support from mentors and peers helps students manage the stress of integrating complex new technologies. Prior experience acts as a moderator, regulating how effectively a student adapts to their training. Admitting a high-scoring student provides the potential, but the absence of these structural mediators prevents that potential from translating into clinical competency. We can combine these data points into a unified competency pipeline. The pipeline begins with the TEAS. Instead of a gatekeeper, it functions as a diagnostic tool, identifying where students need targeted mastery support. The MMI then filters for clinical judgment and ethical resilience, traits that cognitive tests cannot reach. Finally, the institution must provide the environment described by the structural equation model, fostering self-efficacy to ensure retention. This architectural approach targets specific benchmarks, NCLEX RN pass rates exceeding 90%, and high levels of graduate job satisfaction, driven by the alignment of training with personal self-efficacy. Securing the healthcare workforce requires a shift toward a holistic, mathematically verified architecture of selection and support.